Do you have patients who report significant levels of pain, but their tests are coming back normal and not showing an explanation for this? This can be confusing for us as clinicians, but also very distressing and frustrating for patients, as they're made to feel that their pain isn't being taken seriously, or that we're going to suggest that it's all in their head. In this video, I'm going to share how I explain normal investigations to patients in 2 easy steps, so that you can help your patients make more sense of this, helping them move forward. At the end of this video, I'll go through an example of how I explain worrying sounding but normal MRI findings to my patients. Hey friends, welcome back to the channel. If you're new here, my name's Mahin and I'm an advanced practice physiotherapist specialising in pain management based in the UK. On this channel, we explore ways to improve our interactions with those living with pain to help them create healthier and happier lives. Today, I'll be covering why tests come back normal even when someone's experiencing a significant level of pain and how you can explain this to your patients. So let's get into it. The first thing to do is to get a better understanding of how pain works. So ask your patient whether anyone's explained to them before how pain works, and regardless of whether they say yes or no, ask for permission to explain this to them again. And this is how I would do it. I usually start off by saying that pain is one of our protective systems, and we have many different protective systems for the body, our pain system being one, fatigue system, stress system, and our immune system. Now, pain responds to anything the body sees as threatening. Note I use the word body here rather than brain straight away because it's an easier in for patients rather than jumping straight to brain, which may suggest that it's in their head. So, pain responds to anything the body sees as threatening. Now this might be if you twist your ankle, pain's there to stop you from walking on that ankle, to stop you from doing any further damage to that ankle. But pain also responds to anything else the body sees as threatening. And this can be things like stress, poor sleep, lifestyle changes, or any previous trauma someone's been through. Now the confusing thing is, pain doesn't tell us what it's showing up for, it just shows up as pain. The idea that we're trying to get across here is that pain is multifactorial and there are lots of things that influence it. I actually don't use the word biopsychosocial with patients because I don't know how much that actually means to people. It's just kind of a big word, a collection of a few things. But what I do instead sometimes is I explain that sometimes when we go through stressful periods or we go through significant life events, our body can't express what it's feeling through emotion, so it expresses it through physical sensations like pain instead. And I took this from a book that I read last year called Is It All in Your Head? And I'll leave a link to that in the description below in case you want to check that out. But when explaining this to patients, in short, I say that anything that makes you unhappy makes your pain system unhappy. Then I ask them to reflect on this and just to see if they've got any evidence of this from their own life or whether they've found this in their own experiences before. And most of the time people will be able to find examples from their own life when other things apart from, structural changes or damage has, led to more pain. And it's really important to do this bit because for patients, anecdotal evidence holds so much more weight than research evidence. We can tell patients about all the research evidence that's out there, but actually helping them to see where this has been the case in their own life is so much more powerful. And if they're struggling with this, you can help them by using other examples of pain. So for example, I use headaches quite a lot because headaches are quite frequent for most people, but if we actually did kind of a brain MRI, we wouldn't see any changes on the MRI scan, but there are lots of things that do create headaches. So patients often then come up with, if I'm feeling stressed, I might have a headache, if I've spent too much time in front of a screen, if I haven't drank enough water. So they're starting to see then how other things, apart from damage, kind of leads to pain and wider factors that lead to pain as well. The other thing that we can draw attention to are other physical sensations such as increased breathing rate, shallow breathing, increased heart rate, sweating when someone's nervous, for example. So what's really important is letting patients know that little bit more about pain before we go into an explanation about why their investigation findings may not have shown a clear explanation for their pain. And unfortunately, there is no such thing as a pain scan or a pain test. And this is because pain is complex. So we used to think that pain used to only be there because of damage or structural changes. So if we did, let's say, an MRI scan on someone, it would show the damage or the structural change and we would know the cause for the pain. That's what we used to believe about pain. And we didn't really know much about nociplastic pain back in those days. If you're struggling with the terms nociceptive, nociplastic and neuropathic pain, I'll leave a link to another video where I explain these terms in full detail and I'll put that in the description below. So we used to think that pain only existed because of damage and we'd be able to see this on scans. We now know that this is far from the truth, and we now know there's a whole wide variety of factors that influence pain. And this is particularly the case for pain that has lasted longer than the normal tissue healing time of 3 months. And this pain is now called chronic pain when it lasts for longer than 3 months. And this has been the biggest change in our understanding of pain. And this has really been in the last kind of 10, 15, maybe 20 years. And the biggest change in this understanding is that pain does not mean damage. And it is not only influenced by biological or structural factors. And this is why it's very common for tests to come back normal and not show a clear explanation for pain, even when someone's experiencing a significant amount of it. And this is because tests like scans only show structure and potential damage, and blood tests show biochemical changes only. And these factors, structure, damage, or biochemical changes, only make up a very, very small part of what influences pain. And this is the limitation of investigations when being used to diagnose pain. So really we need to look at the whole clinical picture. We need to take into account the history from the patient, because then we can start to formulate a picture of what type of pain this may be and why these scans or these tests or these blood tests may be coming back and not showing a clear explanation for someone's pain. Sometimes as health professionals, we have to take ownership of the impact that we have on a patient's long-term outcomes through the use of our own language and the way that we explain investigation findings. There are some very worrying sounding words used in reports that are actually very, very normal, and they should be explained as so. Before a patient actually goes and has a scan or a test, I like to pre-warn them about these words and reassure them that they are normal despite sounding worrying. And the reason I like to do this is because if a different professional actually tells them the results of their report, then they are aware that some of those things might be normal because I've let them know about that beforehand. What we say to patients and how we say it is so much more important than we initially think. Once we've said something to a patient, we can't unsay it and they can't unhear it. I mean, how often have you had a patient who's hung on to a phrase or a word that someone said to them, even 5 or 10 years ago? I've had so many patients that have come in and said, 10 years ago, I saw a surgeon who said that my spine was crumbling and I'd be in a wheelchair or need to have an operation at some point. Or, I saw a physiotherapist who said that my pelvis was out of line. These phrases really stick with patients and they are so worrying. And if someone has a belief that they have a crumbling spine when actually they might just have some, disc dehydration and a bit of normal degeneration, which is a normal age-related change, then it's going to change the way that they behave over the years. If anyone thinks their spine's crumbling, they're not going to lift anything heavy. They're not going to do anything, strenuous with their back. And the same for, pelvis being out of line. They're going to be so worried that, I might just step off a curb and it might just pop out. And we know that things are so much more stable like that around the pelvis, around the spine. I mean, our bodies in general are so much more robust than that. But the language that we use sticks with patients. We have to be so, so careful about how we are relaying these reports and these findings. So I'm going to give you an example now of what I say when I'm explaining someone's MRI findings to them that may actually show a potential explanation for their symptoms, okay? And I'm going to use an MRI lumbar spine, okay, in this example. So first of all, before I even look at your MRI report, I do want to warn you about some very worrying sounding but very normal words that are often used in reports. Now, the thing to remember here is when they do MRI scans, they have to report on absolutely everything, okay? Now, there's some very normal findings that sound really worrying. So these are things like disc dehydration, degeneration, disc bulges, and so on. And all of those words, although they sound horrible, are very, very normal, okay? And past the age of 25, we start to see a lot of disc dehydration. We get a little bit older, we see some facet degeneration, and we see a lot of disc bulges as well. Past the age of 30, the older that we get, the more likely we are to find these findings. However, these findings alone are not usually responsible for pain, because we know from studies that patients with pain who have been scanned and patients without pain who have been scanned can have very similar findings on MRI reports, okay? But one collection of people have pain and the others don't, okay? But they might have very similar. So they might have the disc dehydration, they might have a couple of disc bulges, and they might have some facet degeneration. And that's just because, both patients are in their 50s and these are very normal age-related findings. So just in the same way that as we get older, we start to get grey hair, that grey hair is not responsible for headaches. And it's the same with these findings that we see on MRIs. They are just normal age-related findings that happen naturally to all of us over time, but aren't always an explanation for pain. Now, having said that, What we then have to pick out from the MRI report is the things that are more relevant and might be more related to the pain or the symptoms that you're experiencing. So I'm just going to have a look at your MRI report here. Now, apart from the things that I've mentioned that are normal findings, okay, so you do have a couple of disc bulges here at L2 and L3 and L3 and L4, okay, but these are just disc bulges and they are not contacting any nerves, so these are just incidental findings. You also have disc dehydration, as I'd expect to see. If you didn't have any of that, I'd think you're some sort of Superman or Superwoman. But yeah, we see that, and again, not an explanation for pain. Now I'll come a little bit lower here, and you have got one disc bulge at L5-S1, okay? And it does show that the disc bulge is contacting the S1 nerve on that right side. So not a trapping and not a damage of the nerve, but it's contacting that nerve, and it likely may be causing some irritation of that nerve. And from the assessment that I've done today, that does fit in with your right leg symptoms, okay? But now the same way that discs bulge, they can unbulge over time as well, and things can become less sensitized. But there are a lot more things that can influence pain sensitivity and nerve sensitivities, and they're the factors that I talked about earlier when I explained how pain works to you. So from my explanation, are there any questions about that MRI report? So this is how I would explain an MRI to a patient who comes to see me in clinic. You can see that the explanation is quite long, okay? It's so important to reassure them around that MRI and not let them leave with any concerns or worries. And just being honest with them as well around kind of the nerve that's being contacted. If a patient, let's say I've gone through an objective assessment, a neuro assessment, and they have normal neuro, then I will reassure them that even though that nerve is contacted, there is no loss of nerve function. So that nerve is, healthy and it's functioning as it should do, because their sensation's normal, their strength's normal, their reflexes are normal. If it isn't, then I'll let them know. And I'll say, okay, so at the moment, this nerve is irritated and it isn't functioning as well as it was previously, but we can regain function in that nerve. So it's about being honest with the patient, but also not leaving them feeling distressed when they leave your clinic, okay? Because a lot of these things can improve over time, and that's really important to note. If this video was helpful in being able to explain normal test findings to your patients, then you'll like this custom playlist that I've made for professionals working with people living with chronic pain. In this playlist, I have videos on the top challenges faced when working with people living with chronic pain, how to help people with pain in less than 10 minutes, and many, many more. Thanks for watching, take care, and I'll see you on the next video.